With those progesterone fluctuations come sleep disturbances, mood disturbances, anxiety. These are issues that a lot of women in their, late 30s throughout their 40s are encountering, as they're, trying to raise families and as they're working, and it can be very disruptive to their lives. When they go to their providers and explain, these symptoms to them, oftentimes they get put on antidepressant medication or anti-anxiety medication, and really, it's a hormone issue.
Hi, everyone. It's Dr. Sharma, and I'm so excited to introduce Megan Kilkeary, who's a pharmacist who is going to help demystify compounding pharmacy and the role of compounding pharmacy in hormone therapy, as well as possibly other conditions that you might be encountering. Megan, do you mind starting out just telling us a little bit about yourself?
Yes, thank you. Thank you so much for having me. I'm excited to be a part of this podcast that you're doing here. So my name is Megan Kilkeary. I've been a pharmacist for over 20 years. I've been a compounding pharmacist for 18 years, and it's a really exciting time to be a part of the compounding community right now. I've seen so many changes over the years, and definitely in a positive direction. What we can do with compounding and what we can do with personalized medicine is really so impactful to patients. And again, I'm really excited to be here and answer some of the questions that are surrounding compounding. And like we said, hoping to demystify, both compounding and hormone replacement therapy, and just make it more accessible for patients overall.
Thank you so much. And can you can you define for us what compounding pharmacies are and what type of training you have that qualifies you to be a compounding pharmacist?
Sure. So basically, at the heart of it, what a compounding pharmacy is we are taking the raw materials from scratch and we are making medications. And honestly, this is how medications have always been made. I was mentioning earlier to Dr. Shaima that I had the opportunity to visit a museum down in Old Town Alexandria called the Stabler Ledbetter Museum. It's an old apothecary that started in 1792 and was operational for 140 years up until the 1930s, until it went out of business in the Great Depression. It's a museum now, but really walking through those doors reminded me that compounding is truly how pharmacy began, and how, we mixed different ingredients and different chemicals and different herbs. And, it was all about personalized medicine. They even had an original prescription from Martha Washington,
Wow.
in that museum that they had made for her and delivered to Mount Vernon. So, again, it was very impactful, to see that, and again, a really good reminder that, what we're doing now, this isn't something new. We're not reinventing the wheel here with compounding pharmacy. We are just bringing it back around, history repeats itself, and we are back to personalized medicine and making things for patients that they need, and in strengths that they need, and in dosage forms that they can use. As far as from a regulatory standpoint, compounding is, authorized. We are authorized to operate under regulations from the FDA. We follow those very closely. The FDA and what's called the United States Pharmacopoeia. Those are our two main regulatory bodies. Along with each state has its own board of pharmacy that has rules and regulations. So compounding pharmacies operate under very tight rules and regulations, especially when it comes to compounding sterile items. Obviously, sterility and potency and patient safety are of the utmost importance. And so, we send products out to third party laboratories to do independent testing on potency and sterility to make sure that these products are safe before we dispense them to patients. So again, there are lots of regulations that are in place, that compounding pharmacists and pharmacies follow. So it's important to always vet your pharmacy before you choose one. Ask them what type of accreditation boards there's additional going above and beyond just what the regulatory bodies require. There's additional accreditation opportunities that are out there for pharmacies to engage in, and you can ask about that when you visit a pharmacy. Ask if they are PCAV certified, or ask if they are legit script certified. These are important characteristics. So
So pretty much every compounding pharmacy is regulated by the FDA.
correct. Yeah, yeah.
And
Rules and
then
regulations.
okay, and then you can have additional, third party, vetting by asking for the accreditation that you had mentioned.
Correct, yes, yeah, and again, that's just going above and beyond what the
That's right.
regulatory bodies are asking of us. So yes, absolutely, providers and patients are more than welcome to ask any, compounding pharmacy, again, if they are accredited by any of these third-party, industries.
And Monica had mentioned when I was talking to Monica Oni about, hormone therapy and about her practice, she had mentioned, 503A and B, and is that in reference to, the FDA regulations or something else?
Yes. So there are 2 different classifications when it comes to compounding pharmacies. You have a 503A pharmacy, and these pharmacies compound for what we call patient-specific prescriptions. And
Okay.
then there's a 503B pharmacy. These pharmacies are able to compound for office use products, meaning it does not have to have a prescription that has a direct patient name on it. So those products can be shipped directly to the office. 503A compounding pharmacies, we cannot do office shipping. The majority of compounding pharmacies that are out there are going to be 503A pharmacies. I believe there's only a couple dozen 503B facilities across the United States.
Okay.
So those are much less common
Okay.
for you to come across.
And, Megan, could you just describe to us what your training is as far as to be able to be a pharmacist at a compounding pharmacy?
Sure. So right now, all pharmacists, all pharmacy programs are actually doctorate programs. So all pharmacists, we receive our PharmD, and from there, there are lots of additional training organizations out there for compounding. The main one that comes to mind is PCCA. So that's Pharmacy Compounding Centers of America. They're based out of Texas. They are an industry wide leader in providing the chemicals that we use for compounding, in providing resources and education for both technicians and for pharmacists, and also for just compounding pharmacies in general. And so PCCA is where we go to get a lot of that additional training when it comes to compounding, and how to make formulations, and what ingredients to use, and what cream bases to use, and what inactive ingredients will mix in well with the products. So really, compounding, I say it's a lot like cooking.
Mhm.
We follow recipes, we measure things out very carefully. We have balances that we use that are tied to computer systems that can weigh even just the smallest tiny amounts of active ingredient. And if it's off even by just a few percentage points, the computer will alert you to that, and won't let you proceed forward with making that formulation. We even have our balances and scales calibrated multiple times a year, to make sure that they're functioning properly. Our sterile labs, we do different air quality testing within those. We have what's called gloved fingertip testing that we do to make sure that outside bacteria is not being introduced into the sterile environment. So again, lots and lots of safety measures that are put in place to make sure that the products we are making for our patients are of the highest quality.
So after finishing pharmacy school, um, most graduates would take a traditional path and go
Right.
into a traditional pharmacy
Right, or hospital, yeah.
or a hospital-based pharmacy. What was what was it that triggered you to go into compounding?
That's an interesting question. I when I first started, and in compounding, um, it wasn't by choice. It just kind of it fell into my lap, and I thought, "Oh, maybe I'll stay here for a year or 2 and
Uh-huh.
try it out and see what it's all about." And it was funny, I absolutely fell in love with it. I fell
Okay.
in love with personalized medicine
Yeah.
and with truly helping patients. And, once, that kind of got into my blood, I said, "This is it for me. I'm a compounding pharmacist," and this is my career path going
Yeah.
forward. But yeah, coming out of school, I this wasn't, kind of in the cards for me initially.
Okay.
So I'm very thankful that, I took that leap and I tried it out because it was the best thing I've ever done.
That's
And,
amazing.
yeah, and I truly love what I do, and I think the opportunity to work so closely with both patients and providers and to really feel like you can make a difference in someone's life, with personalized medicine, and especially when it comes to hormone replacement therapy. It's incredible. You can really change lives. And I think being in healthcare, that's what we're here for.
For sure. And can you explain to me a little bit about um, how much screening is done at different compound? And I understand this might vary between pharmacies. Um, but I know when I started practicing many years ago, more than 25 years ago, because I didn't know a lot about hormone therapy, I would actually refer patients to a compounding pharmacy, and I would have them do the questionnaires that are related to menopausal symptoms,
Yeah.
and the and based on my review of the forms, it was differentiating symptoms that could be related to low estrogen, symptoms related to low progesterone, or symptoms related to low testosterone.
Mhm.
And then the creams were adjusted to, like you said, adjusted individually to
Right.
to help um, help alleviate the woman's symptoms. Can you talk a little bit about whether pharmacies are still doing that kind of screening and whether they're doing any other testing, like we mentioned urine, saliva, serum testing?
Sure, yeah, and that is, a big, component to a lot of compounding pharmacies is, having a hormone replacement therapy consultation program. We understand that a lot of providers, are getting patients that are asking and wanting BHRT therapy.
Can you
Yeah.
define BHRT?
Oh, I'm
So,
sorry. Yes, BHRT, bioidentical hormone replacement therapy. Yes,
uh
yes. A lot of providers just don't have the education or the background or honestly even the time that it takes to see patients from that perspective and help them work through the issues with their hormones, the perimenopausal patients, the menopausal, the postmenopausal patients. So oftentimes they would refer to the compounding pharmacy, and a lot of compounding pharmacies do have a dedicated pharmacist on staff that will work with the patients, that will go through their past medical history with them, will go through questionnaires, we'll look over, different lab work, whether that's serum or saliva or urine testing, and help to make those recommendations. Now, as pharmacists, we don't have prescriptive authority when it comes to writing hormone prescriptions, but we can make those recommendations to the provider and also provide them with the rationale for why we're making these recommendations, based off of this lab work, based off of these chief complaints, based off of these symptoms. This is what I would recommend. And so that gives providers the option to then take those recommendations or even make some slight adjustments to them, and then authorize the prescription to the pharmacy. But it's really it's a team effort,
Yeah.
when it comes to that type of collaboration. And I think that's really nice. It benefits, benefits everyone.
Yes.
So, the patient is getting their needs met. Providers who, may not have the time or the understanding within their practice, but want to still help those patients are able to still do so. And I think it's a beautiful collaboration.
I agree. I agree. And it's a I think especially in the healthcare model that many providers are working under,
Mhm.
it's so valuable to be collaborative like that. It just provides better care for each patient.
Absolutely.
If you could give us a an example of a patient that you worked with that had either unusual or common symptoms of menopause and how you were able to titrate the hormone therapy for her personally.
Yeah. I think one of the most rewarding patients that I worked with, she had previously had breast cancer. And so she was on an aromatase inhibitor after having gone through all of her treatment. And so this particular medication that she was on, it basically threw her into menopause. And so she was having a lot of the hot flashes and the night sweats, and specifically a lot of those vaginal symptoms that come with loss of estrogen. Terrible vaginal atrophy, dryness, painful sex, recurrent urinary tract infections, and she was honestly just miserable. And so every doctor that she kept speaking with just told her that you are not a candidate for any type of hormone therapy. You're not a candidate for anything that's going to bring you relief, because of your breast cancer diagnosis and because of this aromatase inhibitor that you're on. And I remember, she came into the pharmacy and, we were speaking, and I was explaining to her that new clinical literature has come out that is showing that we can safely use vaginal estrogen preparations in patients that have previously had breast cancer and not increase their risk of recurrence. And so, we talked about the different options because there are different estrogens. We have weak estrogens like estriol, we have more potent estrogens like estradiol. So we talked about what those options were. I even gave her some of the references for the clinical literature to take back to her provider, and show them that we have the data out there that we can safely help these patients that are suffering. And so she did find a provider who was willing to write her a prescription for some vaginal estrogen cream. And I remember her coming back in and just almost in tears. She was just so grateful to finally have an option that was going to bring her relief and just improve her quality of life. She had just been told no so many times and had the door shut in her face and just told that there was nothing that could be done about it. This is how it was going to be going forward if you want to n- not have a recurrence of your breast cancer. And so but we were able to again, convince her physician otherwise, and just bring her that much needed relief. And so that was a really rewarding moment, for me to be able to use the tools and the clinical literature that we have out there to help a patient and also to educate a provider.
That's remarkable.
Yeah.
And it not only that it brought relief to that woman,
Mhm.
but also seeing how you can use a collaborative approach
Yeah.
to solve a problem.
Right.
And maybe the impact that you had on that provider for future patients that they might be treating in the same situation.
Absolutely, and
That's
even,
wonderful.
that patient, if she's in, support groups and meets other, breast cancer, patients, she can, provide them that information too, and so, that's really what the goal is, for us. Again, kind of, as we had talked about earlier, destigmatizing the thought of hormones and the thought that these are, not safe for patients. And really just kind of use an evidence-based approach to medicine and the clinical literature that's out there, to really have an impact.
I did think of one other question before I ask you about the um, different methods of compounding, and that is, in traditional in our literature, based on a lot of data coming from the Women's Health Initiative, we talk about the um, kind of the timeline of introducing hormone therapy. So we're saying that it's best when it started within 5 years of menopause,
Mhm.
ideally before the age of 60, and used for up to 10 years.
Right.
How are you navigating that information?
Yeah, and I thoroughly agree with that, and I would even take it a step further in that, we need to start treating women as early as perimenopause. We know that the hormones are starting to decline. Specifically, we have a lot of progesterone fluctuations during perimenopause. And the with those progesterone fluctuations come sleep disturbances, mood disturbances, anxiety. These are issues that a lot of women in their, late 30s throughout their 40s are encountering, as they're, trying to raise families and as they're working, and it can be very disruptive to their lives. And so when they go to their providers and explain, these symptoms to them, oftentimes they get put on antidepressant medication or anti-anxiety medication, and really, it's a hormone issue, and if we could address it from a much more natural approach, with some natural progesterone or, with some natural testosterone if it's, libido or energy or fatigue related. And really, again, restore quality of life to these patients, without having to use some of these other pharmacologic mechanisms that are out there. And so, while I agree, I would love if we started women, within 5 years of the onset of menopause. I say, let's start earlier. Let's start in perimenopause and follow them through, and as they're starting to, get closer into menopause and having those vasomotor symptoms, starting that estrogen replacement for them. Estrogen we know has, bone building properties to it, cardiovascular protection, potential for, neuroprotection. So many wonderful benefits to that as well. And so, again, I think, really focusing on starting the patients in perimenopause and carrying them through, is really where I would love to see the conversation shift to.
And I want to let you go, and every time you say something, I want to ask you two more questions. So, okay, so related to that, in perimenopause, of course, women are still ovulating, so there is a risk of pregnancy.
Sure.
So, if they have not had a tubal ligation or the partner has not had a vasectomy,
Mhm.
um, then the options are a barrier method
Sure.
or some type of hormonal method, which would be an IUD or birth control. So, how do you navigate hormone therapy in a perimenopausal woman who also needs uh,
Yeah, and that's a very tricky
protection?
situation.
Yes.
Yes, and I was actually, having this conversation, with, a provider group just a few weeks ago, and the exact same question came up. And one of the other providers, in the room was just saying, "Listen, you need to figure out, what is important, in your life. Do you, want to certainly we can provide you, with these options with, the progesterone and the natural progesterone and natural testosterone and estrogen if you need it. But yeah, you have to make a choice. And and that doesn't mean, I work with plenty of women who are using IUDs,
Mhm,
like Mirena, which is a progestin, which is not progesterone. There's definitely a difference.
mhm.
But plenty of women who are on a progestin, who are still using natural progesterone, for the sleep benefits and for the mood and anxiety. That IUD is really just kind of working locally. That progestin is working locally there. Um, and so we can still have patients, utilize those hormones even on a product like an IUD. In fact, oral contraception, birth control pills, that's one of the main reasons why we see perimenopausal patients have low testosterone levels. Oral contraceptives reduce testosterone. And so that's extremely common. And so we can still, if a patient wants to continue using their oral contraceptives, we can still provide them with some testosterone therapy to help increase their total testosterone and combat things like fatigue and low energy and help encourage muscle building. So it's still an option even with birth control.
Birth control.
Mhm.
Okay, excellent. And um, when we are using topical estrogens, I have been taught that you still need to have an oral micronized progesterone to in women who have a uterus to offset the effects of the topical estrogen. How do you approach that? Because oftentimes compounded creams are compounded estrogen, progesterone, and testosterone, and I'm assuming then that is the only progesterone delivery that's happening.
Right, yeah. And, it's funny when I first started compounding, over 18 years ago, I saw so much topical progesterone. I was dispensing so much of it. But I don't think we really knew back then that we weren't getting that endometrial protection from the topical formulation. And I'm thankful that over the years a lot of the topical progesterone use has really slowed down, and we're focusing more on oral progesterone, or if a patient can't tolerate it orally, we can use a vaginal progesterone as well. But I am also a fan of, even in women who don't have a uterus, of still using progesterone. That's a big thing that I hear a lot of times from OBGYNs. Oh, she had a hysterectomy, so we're just going to use estrogen. We don't need progesterone. And I say,
Yeah.
we have progesterone receptors throughout our body. We have them in our brain and in our breast tissue and in our bones. And so, why not still use a progesterone supplement for all of those benefits for the receptors throughout our body, even though we don't have the uterus, or that patient might not have the uterus. So I
Yes.
feel like, that's a big, kind of misconception that's out there, that no uterus, no progesterone is needed. And, like I said, I am a huge fan of still using progesterone, even without a uterus. And there's something, one of the lab tests that we look at too is called, the estrogen, estradiol progesterone ratio. It's important to make sure that those numbers, are in line with each other. And so when you are only supplementing with estrogen and not with progesterone, that balance can get out of whack, and we don't want to cause estrogen dominance either. So
Okay. So So talking about levels, you try to maintain a potentially an estrogen progesterone ratio of approximately 1?
Correct. Well, yes, it no, it's gonna actually depend on kind of if we're looking at serum or urine
Okay. Okay.
or saliva, but yeah, there is, a ratio range that we are shooting for with those, so.
Okay. And when you are using testosterone, are you treating to a woman's symptoms, or is there a blood level that you're also looking at? And I know that we all vary in how we use blood tests. One of my guests, uh, Monica, uses blood tests more frequently than perhaps um, uh, the gynecologist, Dr. DeHaven, or myself do. But it's a learning process for me as well, and maybe I will use more blood work to guide me. But what are you looking for in a testosterone level when you're replacing hormone therapy?
Yeah. So, I am a big fan of, symptoms and lab values. I don't think you can use one without the other when making adjustments for patients. Specifically when it comes to testosterone, we're looking at total testosterone. That's important. But the other thing too is the free testosterone level. The what's free is the unbound hormone that is available for the body to utilize. And so, I've seen patients that have a total testosterone level that looks good. It's within range. But they're still very symptomatic. And the problem is their free testosterone is extremely low. And so that can be due to a lot of other things like sex hormone binding globulin. But so again, you can't just take a number and not look at the symptoms too, because I've definitely seen that happen, and I've also seen patients who their numbers look good, they're within range, but they're very symptomatic of low testosterone, and so sometimes it's okay to potentially push outside of that range, to what a lab might say is a normal testosterone range. That's not necessarily, it's not a one size fits all answer for everyone. And so while a lab may say that a high value of serum testosterone is 75, you might have a patient where her symptoms are not controlled until she gets up to 90 or 100. So, I think it's a balance, and we can't be stuck on just looking at symptoms or just looking at lab values. It's a fine dance between the two, and every patient is going to be different. You'll have one patient, you'll get her testosterone to 50 and she feels like $1,000,000, and you'll have another one who's at 50 and just is extremely symptomatic. So
Okay.
again, hormone replacement therapy is truly personalized medicine, where we have to look at every patient individually.
The concept that you have tied in between compounding between compounded medication and personalized medicine. And
Yeah.
there is, I think, I am also learning as the more I practice that we have guidelines that are important and valuable for population health,
Mhm.
and then we have individual medicine that is also equally important
Yeah.
for each of us. So
Yes.
I am very thankful to you and other compounding pharmacists for the work that you're doing and the guidance that you're also providing to providers. So I appreciate it, Megan.
Yeah, absolutely. And thank you for having me. I appreciate it.
You're so welcome.